We are getting started right now.
Hi, everyone. I'm Dr. Emily Ricketts, and here we have Dr. John Pasantini. And sorry, things are, now I can't see my slides. But yes, so we are excited to present to you today recent discoveries in Tourette syndrome, a research update for patients and families. And it is brought to you today by our Tourette Association of America Center of Excellence at UCLA and the TAA Southern California chapter. And we're excited to have our friends and colleagues with us today. So from Tourette academic centers around the state of California. And so today you will be hearing the latest advances in terms of behavior therapy, light therapy, sleep, and the 24-hour biological clock, imaging, brain waves, and also stigma as well. So yeah, we have a great lineup for you today. And also just to give you some background, ultimately this research update originated from all of you. So, our chapter members locally had expressed interest in wanting to learn more about the local goings-on in terms of research in their own neighborhoods. And so, this is how we developed this program for you. So this is the reason why we have researchers here from Stanford, UCLA, UC San Diego, and San Jose State. However, this, as you know, this research is certainly broadly applicable on an international scale. So now Dr. John Pasantini will talk about our Tourette Association Center of Excellence.
Hi, everyone. Welcome. I just want to echo Emily's welcome to you. We're really excited to do this. It's been a fair amount of time in the planning. And I just want to very briefly describe the Tourette Center of Excellence at UCLA, which is the host of this program. And it's directed by myself, along with James McCracken, as co-director, child psychiatrist, and Yvette Bordelon, who is a neurologist. And the goal of our center, as most of the centers, is really to provide excellence in clinical care, research, education awareness, and education outreach advocacy. And we provide a number of services at our center, really scanning the gamut of what we believe are important for working with families with and children with Tourette's.
All right. And now we will hear from Tracy from the Tourette Association of America. So she is going to tell you a little bit more about the Southern California chapter.
Good afternoon, everyone, and thank you so much for joining us this Friday afternoon. We really are excited to present this, and I want to thank both Emily and John for including us with this in this collaboration. Just a little bit about the chapter. If you're located in the Southern California area, we have a very active chapter there. But what our chapter network really does is provide support, resources, networking, and awareness at the local level. And, in partnership with the UCLA C of E, the TAA C of E, we work together hand in hand to, connect and to provide the support and care that the Tourette syndrome community needs in Southern California. So I encourage you to reach out to the Southern California chapter if that's closest to you. If not, and you're dialing in, which I see many of you are dialing in from outside of the Southern California area. Thank you for that. There are national centers of excellence located throughout the United States and a number of chapters. So if you need information, please reach out to the Tourette Association of America, our national headquarters at tourette.org for more information or to find your local center or chapter. Thank you so much.
All right, thank you so much. And now we will hear from Dr. Flint Aspil from the Department of Psychiatry and Behavioral Sciences at Stanford. And let me stop showing my screen.
Hi, everybody. Let me just start this off here. All right, hopefully you can all see this, and welcome, welcome, welcome. So I'm Dr. Espil. I am at Stanford in the School of Medicine, and today I'm going to be talking a little bit about CBIT lately. So we'll probably spend 2/3 of the presentation talking about some of the long-term outcome data that we have from a recent trial. And we'll also talk a little bit about some imaging approaches, some novel imaging approaches. Before I get into it, of course, have to thank a much larger team who makes research like this possible. So people from all over the country, you've probably heard from them before in previous webinars, and you'll hear from them again in future webinars. You may even recognize some names on there from the talk today. But huge thank you to everyone who makes research like this possible. In addition, of course, to all of you families, folks with Tourette, thank you so much for helping to advance our understanding of Tourette and tics more generally.
Dr. Espel, actually, hold on. Your
Yes.
presenter mode, are you able to make your main screen the presenter screen?
Yeah, let me see if I can do that. Let's see. How's that? Did that work?
So if you, let's see, if you go up to slideshow and
Oh
then.
goodness, there's always one person with technical difficulties. It
Yeah.
appears it's me.
Okay, so do you see the part where it says use presenter view on this top tab on the, so slide over, keep sliding the cursor to the right.
Oh.
Yeah, so keep going, so that you see where it says automatic. Is there a way to get that to not be
Let's
gray?
just uncheck that. And let's see if this works. Primary monitor.
Yeah, perfect.
From
That's it.
beginning. All right, did we get there?
Yes.
I will assume yes. All right, thanks, Dr. Ricketts. Okay, so where was I? So these are the three main things that I'm going to talk about today. So I'm going to provide a little bit of background on CBIT for those of you who may not be as familiar, and talk a little bit about how we have some follow-up data that suggests that early intervention might be helpful. And then we'll finish off with with an overview of a novel imaging approach that myself and some colleagues at Stanford have been using to help us understand, perhaps, or begin to understand who might respond to CBIT and what might be going on when people are practicing CBIT skills. So let's start with CBIT itself. And again, some of you may be familiar with this, maybe you've even tried CBIT, and hopefully it's been helpful. But for those of you who are less familiar, CBIT is this behavioral intervention that's been around for a couple decades now, but it actually stems from a behavior therapy approach that goes way back to the early 70s, and it was called habit reversal training. It was developed by Azarin and Nunn, and they published a paper in the early 70s where they looked at using behavior therapy approaches for people with tics, but also for other sorts of repetitive behaviors like skin picking or nail biting or other things. And they found that it was actually fairly effective. And then there were some studies that were published throughout the 70s and the 80s and 90s, and then eventually a large group of very smart individuals got together with the Tourette Association, and they created CBIT, which was kind of a collection of various behavioral approaches that we know can be effective, and put them all together and developed this packaged treatment. And then they tested it in a trial, which we'll talk about in just a moment. But CBIT has these various components. And I won't bore you by going through the slide and reading these off one by one, but I can tell you that there's some background on tics, kind of why we have tics, what we know about tics. The knowledge really is power, and so helping to explain what sorts of things we do understand about tics can help people with tics and family members of people who have tics understand why it is we do what we do in therapy. Then there's this idea that the environment can influence tics, and as I'm sure a lot of you know, there are times when tics are more severe And there are times when tics are less severe, and that can fluctuate during the day. It might fluctuate over the course of weeks or months. And so sort of figuring out what those variables, those things might be that influence tics, either externally in the environment. Maybe I tic more when I'm doing my homework, or when I'm playing video games, or right before I have to give a speech, or in the internal environment. Maybe when I'm really stressed or anxious, maybe I tic more. So figuring out what those variables are for you in particular, and then creating interventions to help intervene, to make it so perhaps these external and internal environmental variables have less of an influence on ticking themselves. Then, of course, you can see the habit reversal training there. And so this is this idea of, in habit reversal, what we're trying to do is we're trying to increase awareness of tics and tic-like warning signs or sensations, or urges, as another term you might be familiar with. And then we come up with things that folks can do physically and actively to help manage their tics or block their tics. And we call those competing responses. And I know this isn't a CBIT talk, so I promise I won't go too in depth here. And then it's a matter of practicing those tic management strategies and involving parents or significant others to help practice those competing responses. There's also a reward system, especially for younger kids. CBIT is a fair amount of effort. It's a fair amount of work, and so we like to reinforce, or we like to reward that effort. Doesn't matter what the tics do in treatment, but if kids are putting in effort, then we absolutely want to recognize that. There's also a relaxation training piece, just given that across the board, for most people, I won't say for everyone, stress seems to make tics a little bit worse. And so having some relaxation techniques that can be implemented in a variety of settings can be really helpful. And standard CBIT is 8 sessions over about 10 weeks. That's the manual. So if you did the CBIT in a research trial, that's what you would probably do, with some exceptions. But in outpatient care, you go and you meet with a therapist, occupational therapist, psychologist, social worker, whoever, right? Once a week. Maybe you have fewer sessions, maybe you have more sessions. It can certainly vary. All right, so CBIT is now considered a first-line treatment by several organizations, and many of you may not know what first-line means. What that means is that, in general, a lot of these fancy organizations recommend that when tics start to appear and they start to become a problem for kids and for adults, that CBIT should be one of the first recommendations that are given. Now, that doesn't mean that if, for example, you're on medications right now, or you're trying another approach, that you should just drop that and say, nope, I need CBIT. That's what I need right now. If you're using an approach and it is working, then great. But in terms of just, come in to a doctor's office, first time working with a therapist, for example, CBIT tends to be the approach that a lot of these organizations, recommend that you try first. And we know, based on several studies, I won't get into the nitty gritty of all the studies and all the fancy statistics. They're out there, and if you're interested, you can go to the Tourette Association website. You can find those papers. There are plenty. But we know that in general, CBIT tends to reduce tics for youth, for kids, teenagers, and for adults. Now, the issue with those studies is that a lot of them don't follow folks beyond about a year. And so you can see in adult studies, they've followed people for about 6 months after treatment, and for youth, after up to about a year after treatment. But we historically haven't known how long improvement lasts, and we don't really know if getting CBIT when you're younger actually changes or influences the course of tics more generally. So these, I know I said I wouldn't get too into statistics, but I'm going to show you some graphs. so these are the results from the biggest CBIT trial of youth ever conducted, and it was published in 2010 by none other than Dr. John Piacentini, who's on this call, and a large group, working group, along with the Tourette Association. And there were 126 kids in this study, and half of them got a PST, which is psychoeducation and supportive therapy, just kind of coming in, how was your week, what kind of problems do you want to solve today, and half received CBIT. And what we saw is that after 10 weeks, so after that initial treatment period, the people who received CBIT were doing better in terms of their ticking than the people who received the supportive condition. And when we actually looked at something fancy called responder status, we saw about 53-ish% of people who got CBIT were considered treatment responders, and only about 19 were considered responders who received psychoeducation and supportive therapy. So this was a huge trial, landmark study for CBIT, really helped push this idea that behavior therapy, when studied and on a much larger scale, could be helpful. But what we didn't know were some of these questions that I brought up earlier. What happens after treatment? And so we did a 10-year follow-up study. And the way we did it is we attempted to contact all of the youth, many of whom were now adults, who were in the original CBET trial. And then what we did is, and the study was conducted at 3 different sites. And then we did either in-person assessments, this is pre-COVID, mind you, or we did Skype assessments. And we had a primary sort of measure of outcome, or 2 sort of measures. And there's this scale that we use, and maybe many of you have done this if you've ever worked with someone on your tics. It's called the YGTSS, which stands for the Yale Global Tic Severity Scale. It's the structured interview that a clinician or therapist will use to kind of understand what tics are happening recently, and then they can calculate a severity score and an impairment score. So severity, just how frequent, intense, often the tics are happening, and impairment is more how much do the tics interfere with things that I might need to do on a day-to-day basis. And those scores range from 0 to 50. Those are actually the scores I showed you in the previous slide as well in that graph. And so in terms of the participants in this follow-up study, these are the overall demographics. We had 80 out of the original 126 who agreed to and were able to participate, which is great. 10 years later, I'll take it. That's pretty good follow-up given how much folks move around. That just consistent with the original trial, there were more people who were white and male. At follow-up, 29 folks said that they were on tic meds at that time. Among the 80, 38 were assigned to CBET in the original trial. Now you can see that about 47 said that in the interim between when they finished CBET and when they came in later, about 47 had received some mental health services for sort of any condition, but only 5 had received services for tics between the time that they ended the study and the time that they came back in. All right. Let's go on to the next one. So this has a little more information that I think will be helpful for you. So when we brought people in 10 years later and we asked them, do you have any co-occurring disorders? About 50% said, nope, it's just the tics. And then about 25 said, yeah, maybe I struggle a little bit with ADHD, or maybe I have OCD, or maybe I have some social anxiety, right? So they reported that they had one other co-occurring problem. And then there were about 15% who said that they had 2 co-occurring problems. Then you can see that kind of dip off. So about half the sample, no co-occurring problems, and then the other 50%, it kind of tapers off as we go through. This is a pretty busy graph, so I apologize. But basically what this is looking at is it's looking at different kinds of other problems that people in general, as well as people with tics, will often report that they struggle with. And the green bars are what kids reported and parents reported their kids had when they came in way back in the 2000s. And the gold or yellow bars here are what they reported at long-term follow-up. And we wanted to see, was there any movement? Was there any change here? And we know that there certainly was, right? So if you look at GAD, which stands for generalized anxiety disorder, you can see that there were a lot more kids who reported struggling with general anxiety when they came in over 10 years ago compared to follow-up. Same thing with ADHD, certainly still some higher numbers there, but there were fewer who reported they struggle with ADHD at follow-up. Now, when we run our fancy schmancy statistics and we say, yeah, there are differences, but are they statistically significant? Which means, is this just occurring by chance, or is there actually something to this? And if there are any statisticians out there, I might be oversimplifying that a little bit, so I apologize. But when we run some statistics, we see that there were actually only 2 categories, I believe, where there was a significant difference, where we would say, yeah, there might actually be something going on here in terms of a change. And those were in ADHD and social anxiety. So those differences there would be the ones that we might consider, maybe there is a shift going on in terms of the numbers here. Then we kind of wondered, does CBET influence the occurrence of other conditions? So if I get CBET when I'm a kid, is there any difference in terms of the presence of other problems that I have later on? And the short answer for that is no. So when we looked at the people who had CBET versus the people, which are the green bars, versus the people who had the supportive therapy, which is the blue bars, you can see that those bars are roughly equivalent as we go through. And so they're about the same. Now, here comes the questions that I am most excited about. So what happens to tics over time? So again, we have severity and we have impairment. So just in terms of how severe people reported their tics were, you can see they go from baseline when they first came into the original study to 10-week when they finished the original study to 10 years later. And when we look at that difference, we actually see that that's significant. So overall, people's tic severity from when they're, roughly, I think the average age in the previous slide was around 10 or 11 for the kids who were in the trial when they first came in. So from then to 10 years later, you can see that the severity decreases. And then in terms of the impairment, so how much of a problem are my tics? How much do they get in the way of, my schoolwork, my job, my relationships, my ability to focus or other things? We see that the tic impairment also decreases. So there's that big decrease from from baseline to 10-week, and then an even further decrease up to 10 years. So that's the good news. So people are feeling better. They're feeling like their tics are causing less problems and are less severe as they get older. And now here's where things get a little tricky. So I'm going to simplify this. So this is baseline when they first come into the study to when they finish the study post-treatment to 10 years later at long-term follow-up. And those two dashed lines on the top, those are people who either had CBIT or the supportive therapy, but they didn't respond. They didn't get any better at post-treatment, right? And so you can see in terms of tic severity, there's not much of a change from baseline to post. And then there's a little bit of a decrease as they move into 10 years later. But for people who do respond, we see a different trend. So this blue line and this green line, you can see that there's this decrease, right? So from baseline to post, their tics become less severe. But when we assess them 10 years later, the people who were better at the end of treatment in the supportive therapy group, their tics actually kind of returned to baseline. They became more severe over the course of 10 years. But for the people who had CBIT, their tics were less severe and they stayed less severe 10 years later. So there might be something to early intervention here with CBIT in terms of tics getting less severe if you respond and staying less severe over time, which is kind of what I summarize here. So if I have CBIT as a kid, if I respond, I maintain those gains. If I don't respond, there's some improvements over time, but it's not quite as meaningful. And I'll just go back here real quick. So what I mean by that is, even for people who don't respond, they still continue to improve, but it's not quite as low. If you can see the severity is not quite as low it is for that green bar there. If you have supportive therapy as a kid, if you respond, you don't maintain the gains. And if you do not respond, then you have similar outcomes for the people who relapse. All right, so the takeaway message here, folks, at least based on these preliminary data, is that effective treatment may alter the course of tic severity. Okay, so what about tic impairment? How much do tics cause a problem for me? Well, again, we have these same lines, right? So on the top, if I don't respond, I eventually get better 10 years later. If I do respond though, right? So this blue line and this green line, I'm doing better at post-treatment in terms of impairment, and then I end up in about the same place later on. So what you can see here is that most people in terms of their tic impairment are doing much better 10 years later. So everybody kind of decreases. But for the people who get CBIT, and to some extent, so the supportive therapy, there's this immediate reduction in tic impairment, and it's maintained later. And so if tics are causing problems for you, and you can get some early help with that, what we see is that even though everyone ends up in the same place, you don't have to wait 10 years to get to that point. So again, here's our takeaways. So regardless of what treatment you receive, your tic impairment is reduced and maintained about 10 years later. And treatment non-responders, certainly less reduction if you look at that graph, but they eventually have similar outcomes. So effective treatment when you're younger may kind of reduce that tic impairment much more rapidly. You don't have to wait the 10 years. You kind of can get that reduction when you're younger and then maintain that as you go through middle school, high school, college, etc. Okay, so where does CBIT go from here? Couple quick takeaways. So I've kind of been saying this, maybe I sound like a broken record. CBIT intervention in childhood appears to be warranted and valuable. Fair enough, right? Based on the preliminary data, at least. As a scientist, we always say we need more data, we need more studies, right? Certainly, but based on these preliminary data, that would be a takeaway. But there are some questions here. So one, how do we approach co-occurring problems, right? You'll recall that half of the people who came in 10 years later were struggling with other things. And I can tell you that there are great resources on the Tourette Association website. There are wonderful therapy approaches like living with tics that also focus on other types of problems that folks with tics tend to have and how to approach those. So I would encourage you to look into those resources on the TAA website. I'm sure most of you have if you're here at this webinar. And then the next question is, how do we increase access to CBIT? And I can tell you that there are lots of very bright minds who are looking into that as well. Dr. Capriati, who will talk a little bit later, put on a wonderful retreat about 1.5 years ago, where a lot of researchers and patients came together and we talked a lot about that. And so we are working on that as a community as well, because it is a big issue. And then there's this last question of responding to CBIT. And not everybody in the original trial responded to CBIT. So about 1/3 of the sample responded really well, about 1/3 saw some meaningful change, and another 1/3 didn't really respond. So there's this question of, when people do respond, why do they respond or why don't they respond? There's another question of, how does CBIT work, right? The brain is a very, very complicated thing. And can we predict response? Is there a way that we could predict who might respond to CBIT when they come into treatment? And there are lots of very bright minds, including a couple who are also going to be on this talk a little bit later, talking about imaging, who have done some great research using fMRI, or functional magnetic resonance imaging. It's a giant scanner. Maybe you've been in an MRI, maybe you've been in an MRI for an arm or leg, or maybe you've actually done a scan of your brain and you've had that experience. And so MRI is a really, really great approach to do that. You get a really high imaging quality, but there are some drawbacks. And first of all, the scans can be costly. If you do it in a research trial, you don't have to worry as much about it, but the scans themselves can be costly, cost a lot of money. They're very sensitive to motion as well, so you're told to lie very still when you're in there. And I don't know about you, but if I'm lying in a scanner and I have tics, that might be kind of difficult. Doesn't mean it's impossible, and there are lots of strategies to help with that, but it can create problems. It also requires that you go to that facility and you do the scan in the giant scanner. You can't really take it into other environments. And when we know that tics are a disorder or a syndrome that is influenced by different environments, it can limit some of the questions that you can answer using fMRI. And so there's another approach that's a little more novel, it's a little newer, and it's got a long ways to go, certainly, but it's called FNIRS, or functional near infrared spectroscopy. And I am not an imager. I am a clinical psychologist with a lot of experience in behavior. I don't pretend to be an imager, and so we're going to talk about this from kind of the 10,000-foot view here. But basically what FNIRS is it's an imaging device where you wear a cap, and I'll show you a picture of it in the next slide. And basically there are all these little optodes and receivers, and an optode spits out some infrared light, and then a receiver scoops it back up, and then it measures what's going on in the outer area of your cortex. That's the outer area, it's the wrinkly part of your brain, and it measures sort of what kinds of activity is going on in that range. And you can kind of see it here in this image right here. So the emitter emits light, and then the detector scoops it up, and it's measuring the activity in this part of the cortex right here. Now, there are certainly some drawbacks here. It is still sensitive to motion. It's less sensitive than fMRI, but there are some motion effects. But it has higher resolution across time. So if you're just looking at activity in the moment, you can actually get even more detailed than in an fMRI, at least based on my understanding. But there is a lower level of imaging detail. It's not as good as fMRI, and limited depth. So fMRI, whole brain, it's amazing. FNIRS, we're just looking at the outer areas of the cortex, but there are plenty of those that are implicated in tics. So that is Shannon. She was one of my first RAs here at Stanford. She's wonderful. She's off in grad school, wish her luck. But Shannon's wearing the FNIRS cap, and that's what it looks like. In terms of FNIRS, we know that it is correlated with fMRI, so they do tend to kind of run together. So if we have someone with a cap on while they're in the scanner, the activity that's measured does line up, but it has some relative advantages to MRI. So one is it's portable. So there are studies where people will have a backpack that has the NIRS machine in it and the cap on, and they'll drive a car, or they'll ride a bike, or they'll go for a run. It's studied a lot in exercise research. And it's also more cost effective. So once universities or institutions buy the units, it doesn't cost a lot of money to actually do each scan. And as I mentioned, it's very flexible across tasks, right? So we mentioned those, but the ones that I'm most interested in and that I'm working with my colleagues at Stanford in are to look at this for CBIT. And so in CBIT, when we're doing habit reversal training, for example, when we're learning to experience urges to tick and do competing responses to sort of block ticks in the moment, what does that look like? What does that look like in the front of the brain, which is an area that's responsible for a lot of planning and organizing and initiating tasks? What does it look like in the top of the brain, which lights up typically before tics occur? And again, for all you imagers, I know that I'm oversimplifying this a little bit, but in general, the idea here would be, how cool would it be if we could have this cap on while we're doing CBIT and we could actually measure what's going on as people are learning to manage their tics? And is there any way that we could use that information to predict who might respond better to CBIT and what might be involved in the response to CBIT? Okay, I've probably gone over my time, so I am going to wrap up here and open it up for questions. If you are interested, if you're in the Bay Area and you're interested in participating in some studies, we're working on getting a tick study up and running. It's not up and running yet. I do have some other studies going on right now. So if you struggle with OCD or depression, in addition to your tics, you're more than welcome to email us here at those email addresses, and hopefully we'll get our tick study up and running sooner rather than later, and there'll be some opportunities for that as well for those of you who are in the Bay Area.
All right, thank you so much, Dr. Espel. So we forgot to mention in the beginning, but if you could place your questions in the chat box rather than the questions box, that will be helpful. So yeah, if there are any questions for Dr. Espel, please type them in. But I will kick it off with a question for you. So, you know, I know obviously you did a lot of work on this for your dissertation, and spoke with a lot of adults with Tourette syndrome about their experiences. And what was your sense of what they took away from CBIT, or what they still use now, or what they liked about it?
That's a good question, and Dr. Ricketts is right. So the data that we used to get the grant from the Tourette Association, thank you again to the association, came from my dissertation. I was in grad school, and so when I did my dissertation, I actually did the qualitative interviews with a lot of the adults, and at least in the initial sample. And what I found, and I know that you, Dr. Ricketts, found some of this because for the larger study, you interviewed some folks, and I know Dr. Piacentini talked a little bit about this as well. But a lot of the adults, when they came back in, when they had CBIT earlier, would say things like, yeah, I used the competing responses and I used the strategies when I was younger, and then as I used those more and more, they almost just became automatic. And I kind of got to this point where I had sort of, could know when my urges to tick were there, and then just not engage in the tick. It was almost like there this almost, I want to say, cognitive control aspect, which means that they would have those warning signs, and they would be able to feel maybe that urge to tick on whatever level, but then continue to give their presentation, or converse with their romantic partner at dinner, or whatever it might be, right? And that was one of the interesting findings. Another interesting finding, at least from my perspective, was how important the relaxation strategies were too, right? We've done some studies and we know that the most important pieces of CBIT are things like the habit reversal. But as people got older, they were still using a lot of the relaxation strategies, and even just in other contexts, like before I give my talk at work or whatever it might be. And so I think it was in the long term quite beneficial for people to have those skills, which was good to hear.
Great, thank you. And then another question we have from Lindsay is, how do we know if tics lessen over time with age versus intervention?
Yeah, good question. And so if we go back to the slides that I had, right? So there's the slide on tick severity, right? And so they had CBIT, and their tics did lessen and they stayed lower, right? Versus the people who either didn't respond to CBIT or had the supportive therapy, their tics still lessen, but not as much. So because we have time there and we're kind of controlling for age over time, we can answer that question a little bit. And again, this one study is not definitive, right? It doesn't mean that 100% this is the case for everyone. But for the people who did have CBIT, who did see reductions in tics, they maintained those versus the people who didn't respond or didn't get it. They didn't have the same amount of reduction.
Thank you. And then, sorry, I'm skipping. There's a lot of questions, so we're probably not going to be able to get to all of them.
Sure.
Would executive function problems affect a person's ability to respond to CBIT? So at least I know in the paper by Dennis. So there was, they had looked at factors associated with treatment response, and they did look at co-occurring ADHD, and it was not significant in terms of its influence on outcome. So, that doesn't mean that it doesn't influence things, in a way, it doesn't interfere a little bit, but it did not rise to statistical significance.
Yeah, then that's a really important point. And again, sorry everyone for nerding out here on statistics, but we also have Dr. Capriati. We'll be talking later, and he's done some awesome work in ADHD. One of the things we talk about a lot in treatment is, where do we start? Do we treat tics first? Do we work on ADHD? Do we work on social anxiety? Do we work on OCD? And typically, kind of the standard approach is if there are other things going on that might be more of a pressing issue like ADHD, then perhaps that's where we start first. Because quite oftentimes, if we can reduce the stress associated with OCD or ADHD or whatever it might be, we sometimes see a downstream effect on the tics, right? Because stress tends to make tics worse. So if we can reduce the stress, the tics might come down. And so, I've worked with lots of kids who have ADHD and tics, and one of the first things we do is we come up with strategies and we make sure that they have the supports, whether that's medication and behavior therapy, et cetera, to help manage the ADHD. And then when we do CBIT, maybe we go a little slower and we impose, we chunk, the information into, smaller steps. We really reinforce a lot of practice. And, anecdotally I've had a lot of success with kids who have both. I'm sure you have too. It's just a matter of recognizing that maybe some of those executive functioning, differences are there, and making sure that you have the supports to implement CBIT in a way that really makes sense and sets people up for success.
All right. Well, thank you so much. I'm sorry, everyone. We're going to need to answer your questions by email, or we'll have to type them into the box, because yes, we'll have to move on. But yes, thank you so much for your questions, and thank you, Dr. Espel. Great presentation.
Thank you.
All right. So next, I will be presenting. For anyone who joined after we did the introduction, I'm Dr. Emily Ricketts. I'm from the UCLA Department of Psychiatry and Biobehavioral Sciences. And so I will be talking to you about sleep, the 24-hour biological clock, and light therapy in adults with Tourette syndrome. So I will share my screen. Okay. And then Dr. Espel, can you turn your screen off now?
Yes, I can.
Thank you. Okay. Here we go. All right. A second. Just trying to get this out of the way. Okay. So yes, again, I will be talking to you today about sleep, the 24-hour biological clock, and light therapy in adults with Tourette syndrome. All right, so we know that there is sleep disturbance in Tourette syndrome. So this has been known for a while. It's pretty common to hear of complaints of difficulty falling asleep, staying asleep, awakenings during the night, sleep talking, even sleepwalking, abnormal limb movements, and even tics happen during sleep for some people, not everyone, but for some. So this has been long documented in studies. However, we don't know much about the 24-hour biological clock in Tourette syndrome. And the reason this is important is because our 24-hour biological clock, which really is referring to our circadian rhythm, this is partly what regulates our sleep and wake patterns. So it regulates them across the night and day cycle during an approximate 24-hour period of time. So, you know, in addition to regulating sleep and wake, it also regulates our hormones, so melatonin and cortisol, for example, in addition to our eating patterns and our body temperature as well. And so the biological clock, or the 24-hour biological clock, has been shown to be kind of delayed in a number of neuropsychiatric conditions, including, you know, ADHD and OCD, but also depression, bipolar disorder, so a lot of different conditions. And so, you know, we did not yet really know much about it in Tourette syndrome. So, so ultimately, I will be presenting some results from two different studies. So the first is survey research. And I should say, actually, before moving on, most of you, I'm sure, have heard of the concept of night owls and morning larks. So night owl really refers to when you are most, you know, you're most active at night. You feel alert at night, whereas morning lark, those people are more active in the morning. And then, you know, it really ranges, so it can be anything in between. Not everyone falls into those kind of polarized opposites. And so that is really the kind of behavioral manifestation of our 24-hour biological clock, or the circadian rhythm. So from here on out, just so everyone's aware, I will be using the term circadian timing to refer to both this, you know, eveningness and morningness pattern or preference, and our more objective 24-hour biological clock. So I will call it kind of the same thing, just to keep it simple. So first, I wanted to present some findings on factors associated with both sleep patterns and circadian timing in adults with Tourette syndrome. So, yes, we did a survey, an internet survey, and we included 125 adults with Tourette syndrome. And ultimately, we were asking questions about sleep disturbance and also subjective or self-reported circadian timing. So this is that morning lark, night owl kind of preference. So morningness, eveningness preference. And then, of course, we asked about tic severity, impairment related to psychiatric conditions, ADHD, OCD symptoms, depression, and difficulties with emotion regulation. So all factors that are associated with, you know, having Tourette syndrome, but are also associated with sleep problems too. So yeah, so we asked questions about all of those things. And here I'm going to jump straight to the results. But what we see is that, you know, in terms of the most important factors that are involved in sleep disturbance in adults with Tourette syndrome, when you analyze them all together in a group, what rises to importance ultimately is obsessive compulsive symptoms, impairment related to, you know, to having, you know, a neuropsychiatric condition, and age. And so I think this is pretty interesting in light of what Dr. Espel was talking about. You know, when we think about the trajectory or the change in kind of symptoms as individuals age, we know that in many, you know, for many individuals, not everyone, obviously, but for some with Tourette syndrome, their tics sometimes decrease as they get older. And sometimes it's the co-occurring conditions like OCD or anxiety, depression, those kinds of conditions tend to be present a little bit more in adulthood, whereas ADHD and disruptive behaviors, and also OCD in childhood too. But yeah, so and this is not to say that tic severity is not associated with sleep disturbance at all. It is related if you're looking at a one-to-one kind of relationship, but when you group everything together, it's obsessive compulsive symptoms that are arising to importance, impairment, and age. And age is, you know, I wouldn't pay so much attention to the age factor. That this is, you know, this is a standard demographic kind of factor. This would apply broadly across people anyway. So the, you know, older age associated with more sleep disturbance in this case. So now when we do the same thing for circadian timing, or this morningness, eveningness preference, so night owl, morning lark, what we find is it was actually tic severity and age that rose to importance. So those were the most important factors that were associated with morningness, eveningness. So tic severity was associated, or increased tic severity was associated with greater eveningness preference. And here age is really associated with greater or older age is associated with greater morningness ultimately, but and that's standard. So we would expect to find that. But yeah, the tic severity finding was really interesting. So yeah, I would say that the take-home points that would, you know, that are applicable to interventions, it's really just that, you know, if OCD symptoms and impairment are, you know, the most important factors here in this study, then they may be ideal factors to intervene on if we're trying to help with sleep in adults with Tourette syndrome. So it's just, you know, things to think about when we are trying to intervene or improve sleep, that those are the things to go after, especially. And then, you know, because tic severity was associated with this greater eveningness preference, this could suggest that interventions that might kind of shift the circadian timing or a 24-hour biological clock, so shifting it earlier might help. And in the next study, I'm going to talk about I'm going to talk about one such intervention. So yes, so it brings me to study 2. So ultimately here, so in the previous study, it was an internet survey, and you know, it was only adults with Tourette syndrome. In this study, you know, it's a much smaller group. It's, you know, 14 adults with Tourette syndrome, but we also have adults who did not have Tourette syndrome or any other conditions, and that was 20 adults. So we wanted to compare sleep patterns and circadian timing in adults with Tourette syndrome and without. And then we also tested a brief light therapy intervention as well in the adults with Tourette syndrome. So let me just explain light therapy to you. So thinking about our 24-hour biological clock, a key factor is that it is kind of, I guess we could say, regulated by a number of factors in the environment. And so the sun and really light, I should say, is most important for resetting and shifting the our 24-hour biological clock. So sunlight is the most intense kind of light there is. So sunlight is the key light ultimately, but you know, you can use other forms of light to help align or keep the circadian rhythm or 24-hour biological clock regulated. And so when you administer morning light to, like, right after waking up, what you'll see is that you will advance or shift your circadian rhythm or biological clock earlier. And if you use evening light, you ultimately can delay it. And so this is why you'll hear articles talking about light at night, light exposure, indoor, outdoor at night. and how we need to monitor this and be more careful. So there have been a few case reports. So very, really only 3 cases across these two reports, but they have trialed morning light therapy for Tourette syndrome, and it's preliminary, but it seemed to be associated with some reductions in tics, and so ultimately, we wanted to investigate that and see if that would be helpful, with more rigorous testing and a larger group of people. So traditional light therapy involves being seated in front of a light box. So just like this woman who's sitting here, you would sit in front of it for about an hour or so, half an hour. But ultimately, the downside is that you need to remain in front of it in order to reap the benefit. And so that could be a little inconvenient, perhaps, and time consuming in that way, especially if you have a morning routine to stick to. So an alternative that has been developed is wearable light therapy. And so you can see here, this is the retimer. So it's kind of like a glasses-like device with no frames. And it uses what's called short wavelength light therapy, which is a green-blue kind of colored light. And the reason they're using this color of light is because it is known to shift our circadian timing. It's kind of a stronger shifting of our circadian timing at lower intensities of light, ultimately. And so this is why we used this device ultimately. And so we had tested this over 2 weeks of morning light therapy at home, wearing it when you wake up, using your average rise time across, a baseline monitoring period that we had before we started the intervention. And then ultimately what we did is, we wanted to find out how sleep was beforehand and after. And we also wanted to find out, we wanted an objective measure of circadian timing also. So for sleep, we had individuals wear this sleep watch or actigraph, and we had them keep a sleep diary. And then for our objective measure of circadian timing, ultimately, we took saliva samples, so several saliva samples in the evening, up until one's average bedtime. And ultimately, what we are looking for is a salivary sample of melatonin, because, as I mentioned before, melatonin is a key hormone involved in our 24-hour biological clock, our circadian timing. And as it rises in the evening, it does bring about, sleepiness in that way. And so we ultimately wanted to find out the time on the clock at which everybody's melatonin, their body's, their natural melatonin reached a certain threshold, and compare it between people. And so we wanted to see if ultimately there was delayed circadian timing in Tourette syndrome relative to those who do not have Tourette syndrome. So now jumping to the results. So this is both for sleep and for circadian timing. So we did see that in terms of, the number of minutes until one falls asleep, and so this is just, comparing adults with Tourette syndrome and those who don't have it. So this is not the intervention yet. We do see that it takes longer to fall asleep for adults with Tourette syndrome. They have poorer, what we would call sleep efficiency, which is kind of like quality. So the percentage of time that they spent asleep while in bed was lower. And there's also a greater degree of restlessness. So those are all coming from our sleep watch. And then also we see that there's greater self-reported sleep disturbance, and then in terms of morningness, eveningness, there's greater eveningness in adults with Tourette syndrome. And you can see that on this graph right here. So we have adults with Tourette syndrome on the top part of the graph. They have greater eveningness. You can see if you look at the direction of the images, that is the direction of eveningness. And then on the bottom, our controls are a little bit skewed towards the morningness side of things. And then we didn't see differences between adults with and without Tourette's on these factors over here. So the time spent awake after falling asleep, the number of awakenings, the total time spent asleep, so sleep duration, and then also our objective measure of circadian timing, which was the melatonin samples that we were taking. We did not see differences on that. And then, yeah, in terms of light therapy, so light therapy, so 2 weeks of morning wearable light therapy, we did see that it advanced or it shifted circadian timing earlier by about 45 minutes. So again, this is the time on the clock that melatonin, the body's production of melatonin reached a certain threshold. On average, we were able to shift that earlier by 45 minutes. It also helped anxiety. It boosted alertness. And that's, we know that light therapy does this, that it also helps, in addition to shifting circadian timing, it does help with alertness and it also helps mood. So this is why a lot of times people have heard of light therapy for seasonal affective disorder and for depression. And then, yes, it did help with tick severity and tick-related impairment. The changes were small. And then in terms of what it did not help, so we didn't see any shifts in the self-reported circadian timing, so morningness, eveningness preference over 2 weeks. We did not see a change in that, although that's maybe not so surprising because, the way that it's asked, it is preference. So I don't know if I would expect that to change over 2 weeks. Sleep, sleep watch variables, we didn't see changes in sleep, whether it was self-report or, the sleep watch. And, for this, I guess our thinking here is that perhaps, we needed a little bit longer for sleep to kind of catch up. And also because of the way that our protocol worked, individuals needed to wake up maybe a little bit earlier than they would have to have enough time to wear it. So, the idea with this is that, you may begin to feel sleepy earlier, and then, you would respond to that by going to bed earlier. But we know, everyone knows that some people tend to procrastinate their bedtime. So not everyone goes to bed when they feel tired because sometimes they have other things to do. And then we didn't actually see a change in depressive symptoms here. So yeah, I was surprised that we did see a change in anxiety, but not depression. But yeah, so that's what we found. So yeah, so even though we did not see an objective circadian delay in adults with Tourette syndrome, we did see self-reported eveningness, that was greater relative to adults without Tourette syndrome. And that's actually pretty consistent with, what we see in other neuropsychiatric disorders. So it's one piece of the puzzle. I do think, it was a pretty small sample in our first time doing this kind of research here. But yeah, it is consistent with prior studies and ADHD, OCD, and other conditions. And then in terms of light therapy, we do we did see some benefits of it. It didn't help with everything, and it was only it's only a 2-week pilot. But yeah, we do see some positive effects on the circadian or on objective circadian timing, tics and tic-related impairment, anxiety, and daytime sleepiness. So in terms of implications for future studies, I think ultimately, it's important for perhaps a longer duration of light therapy. So I think 2 weeks is not really, we need more than 2 weeks to really determine the benefit, especially for tics. And then, certainly this was just a single track kind of intervention. We just had, the retimer, but we didn't really have a placebo kind of intervention. So that's important for making sure that we are doing the best test of how well something works. And then for this, we did not require that, participants had delayed circadian timing, just because we had 2 aims for this particular study. So we couldn't do that. But ultimately, if you're using morning light therapy, this is what you're going for. You want people who do have, a circadian delays or eveningness preference. And then another thing that someone had raised during a prior presentation, which I think is really interesting, is just the thought that light therapy might be able to be used to counter medication-related sedation and sleepiness kinds of effects, just because we know that it did help with daytime sleepiness. So that's another thing to think about. And also, helping anxiety. We know that anxiety is a commonly co-occurring thing with tics. And then the other thing to think about would just be, other ways of administering light therapy so that it's more gradual. So for example, naturally or clinically, if you use light therapy, you would have someone sleep in until the natural time their body wants to sleep in on a weekend, and then you'd work them backwards in 15 to 20-minute increments over several days to get them to where they need to be. But in a research kind of protocol, it's not as easy to do that because people need to go to work and they need to go to school. They have things to do. So we weren't able to do it that way. But that is one way that would be a little bit easier on the body, I think. And then also melatonin is another possible intervention that might help. Just because, and by that I mean melatonin pills. So, melatonin kind of works, I guess the pills work kind of opposite than light therapy, but ultimately, if you give someone melatonin, I guess in the evening, so several hours before bedtime, you can shift their rhythm earlier. So it's not like light in that way. And then if you give it in the morning, you will move it later. So it kind of works opposite of light in that way. And of course, yes, melatonin also can help with sleep onset. Sometimes people take it an hour before bed too. So it can help with falling asleep in that way, but it can also help with shifting circadian timing. And then, and then the other thing, to think about is just, how can we use this to address delays in circadian timing in adolescents with Tourette syndrome? And so, this is a big thing for adolescents, all adolescents, but their bodies naturally do go through a delay in circadian timing. You'll notice, this is why adolescents tend to want to go to bed, stay up at all hours and wake up very late. So yeah, so these are acknowledgements, and now we will, and then for anybody who's interested in studies, this is my research coordinator, Ariel. So you can reach her at this email. And yes, we are currently conducting the light therapy trial in adolescents, 13 to 17 years. So you can reach out to her about that. And then I am going to go to the questions and see what we have. And yeah, anybody asking about the chat box, don't worry about it. After all, I can see the questions that are coming in whatever you see that you're able to put them in on. I'm able to see them. So, Would light therapy help if used when waking up in the afternoon instead of the morning? Well, I would say potentially not, just because, well, how should I say this? I guess yes. Yes. I would say yes if that's when you're waking up. Yeah, it will help, because that would mean that your circadian timing is delayed to that level. If you were already up and you just wanted to use it in the afternoon, then no, that wouldn't work. But yes, I think it, because we're just focused on like where your rhythm is at and shifting it. So yeah, I think that would be fine to use it. If your morning is shifted, then yeah, you would use it upon awakening. Yes, someone said, can it be the sun? Yes, great question. Since the sun is the most intense form of light that we have, you can go outside in the morning and get bright light from the sun instead of using a device. What time of day was the light therapy happening? So the way that we did it in this study was, so it was morning for everyone, but what we did is we had a week of monitoring their sleep and having them tell us what their rise times and bedtimes were. We took the average of their rise times for every single day of that week, and we set that as their as the time that they should rise and start using the light therapy device for 1 hour. However, we know that people wake up later on the weekends and they go to bed earlier in the week, and so that average can mishmash into an average that doesn't make sense for that person. At least for the week, it wouldn't make sense for them to get to work or get to where they're going. So we were allowed to shift this time earlier by up to 1 hour, ultimately. So that's what we were doing in terms of when they were wearing it. Let's see. In terms of the melatonin, so yeah, so it works opposite of light. So light at night will delay you. Melatonin given in the evening, maybe 3 hours before bed, 4 hours before bed, that will shift you earlier, shift your rhythm earlier. If you give it in the morning, like when you wake up, that will shift you later. And then, yeah, and light therapy in the morning will shift you earlier. So it works opposite. And then if you're having difficulties falling asleep, some people like to just take melatonin close to bedtime. And it does also work that way as well. So there are multiple uses of melatonin. The study was done across the years, so ultimately, yeah, across the 2.5 year period or so. So it was not just done in the winter months or summer. So yeah, that's a good question. There could be differences related to season. Yeah, and then ultimately, someone asked about, could clarify why we were doing what we were doing, but ultimately, since we know that circadian timing is disrupted in a lot of different neuropsychiatric conditions, and that it does relate to symptoms, core symptoms of those conditions. Ultimately, the idea is to have an intervention where we can correct circadian timing and see if that does help the core symptoms of those conditions also. So that's really the goal, and also to provide an intervention that could either be used with behavior therapy or on its own, that is kind of a non-medication intervention too. So yeah, we'll have to save the rest of the questions until later. So now I'd like to, actually, let me stop sharing my screen. All right, so now I'd like to introduce Dr. Deanna Green from the Department of Cognitive Science at UC San Diego. All right.
Okay, there we go. I was able to get my camera working.
Wonderful.
Oh, now I lost it for a second. Okay. Hello, everyone. All right. So first off, I do just want to thank the Tourette Association and the organizers for inviting me here today, and thank all the patients and families who are attending. This is a great seminar. So I'm actually pretty new faculty at UCSD. I was at Washington University in St. Louis for about 10 years. So that is really where my lab started using brain imaging to study Tourette syndrome. And there I worked with the Missouri chapter of the Tourette Association. So now I'm really looking forward to connecting with the Southern California chapter more. And as a California native, I'm quite happy to be back home, actually. Okay, so I will be talking about some of this imaging work today. So brain imaging has become a really powerful tool for peering inside the brain of living people. There's a number of different types of brain imaging techniques. Here I'm just showing you a few. So you've likely heard of magnetic resonance imaging or MRI. You go inside the scanner. This machine, which is basically a big magnet, takes pictures of, in this case, your brain. So here. So this is a structural MRI image. You can see nice detailed anatomy there. And then down here, this is called diffusion tensor imaging. It's actually looking at anatomical connections between brain regions. And then this is functional MRI or fMRI, where now we're not looking at anatomy and structure, we're looking at brain function or brain activity. So we can see which parts of the brain are more active when someone is doing a particular thing that we're interested in. I do want to mention here, there's currently nothing you can really see in one person's brain scan that will tell you if they have Tourette's or tics. So Tourette syndrome can't exactly be diagnosed with MRI currently. MRI can be used to view things like a brain tumor, big structural abnormalities, but things like neuropsychiatric disorders can't be viewed in just a single person's brain scan. So actually, what we do when we study the brain in Tourette's or in any population is we average across a group of people. So most brain imaging research is actually conducted at this group level. So we study a group of people, we average brain scans across the whole group. And so, for example, we might scan a group of people with Tourette syndrome, a group of people without Tourette syndrome, and then we use statistics to compare them and look for group differences on average. So we really have to do this averaging to see differences come out. I do want to say that this approach has led to some interesting and important findings. This is just one example of a study that my group conducted. We looked at volumetric MRI. It's basically just the amount of certain types of brain tissue in different regions of the brain. And we compared a large group of children with Tourette syndrome to a group of children without Tourette syndrome. One of our main findings here just showed that the children with Tourette syndrome had reduced white matter volume in the orbitofrontal cortex. That's this region shown here. This was actually a new discovery. So the point is just that we can identify some important differences between groups using this approach. But we know that every person, every individual person is different. So what if we don't want to average across a group of people? What if we want to understand the brain in just a given person? So we know Tourette's is very heterogeneous, right? No two people with Tourette syndrome have a profile. So for example, these two children here, they both have tics. but their tics might be very different. The severity of their tics might be different. Their clinical course over the next 10 years might be very different. There's many things that might be different. So the question is, can we understand what's going on in the brain of each individual child? Now, group studies cannot do this. You have to do this averaging. You need to average across a group of people to get the power to run the statistics that we need. But we know every person's brain is unique. So can we measure or use measures from the brain to really look at individuals? And so in my lab, we're actually working on ways to do this. So the method that we've really focused on is called resting state fMRI, and it's called resting state simply because we ask someone to lie in the scanner and not do any particular task. So in our studies, they're presented with a fixation plus sign like this on the screen, so nothing interesting, and they're simply told to rest, relax, hold as still as possible, which was mentioned earlier, and not fall asleep. And then what we do is we measure their brain activity over time while they are resting like this. So just to give a little example, if we look at a particular spot in the brain, like this blue spot here, we measure the brain activity in this region over time. And so we can see that across a time scale of many minutes, this fMRI signal, this brain activity signal, fluctuates up and down. Okay, so that's what we measure. And so I'm just going to walk through what we get from measuring brain activity in this way. So here again, we have our one spot in the brain that I showed you and the brain activity going down over time. But what we do is we actually measure brain activity like this from every region in the brain. So you have a bunch of different regions, a bunch of different activity traces like this going up and down. And what we do is we correlate that activity from every region with every other region to result in what we call a correlation matrix like this, where basically the color represents how strong that correlation is. So how related are they? So the idea is if that correlation is high, there's a strong functional relationship between those two brain regions. They're said to be functionally connected to each other. Okay, so what we do is we actually get a matrix like this for every single subject. But what you might notice is that it's kind of hard to see a clear pattern in this. There's just a bunch of colors. And so this is why we have to do the group averaging. So when we do this group averaging, so we average all the subjects together, now this is starting to look more like a pattern. You can see clear, bright blocks pop up. And then what we do, we use some statistics and fancy math, and we look at this pattern on the brain like that. And so now we can see what we call functional brain networks. So now we have these functional networks. So each color just represents a certain network. And we can ascribe function to each of these networks based on what we know from neuroscience, from the brain. So just to highlight a few examples to give you a sense of what I'm talking about, this orange, this is called a somatomotor network. All that means is that this part of the brain is involved in somatosensory and motor functions. And in this yellow network, you can see it involves parts of the brain that are in different locations from each other, but they're all actually related. This is called the frontoparietal network. It's involved in things like task control. So being able to really cognitively engage in some task at hand. So it's more of a higher level cognitive network. And so there's a number of networks like this, and it can help us understand how the human brain is really functionally organized. Okay, but remember, this was a group average brain of these networks, right? We have this map of networks, but it's a group. So what we would love to do is map out this functional organization in individual people. And specifically, my interest is to do this for individuals with Tourette syndrome. So is there a way to accomplish this goal for individuals when all we have is this from each person? So the approach that we have been using to work toward this goal is called precision functional mapping. And really all that means is just acquiring large amounts of data from each individual person. So typically in a resting state fMRI study, you would acquire 5 to 20 minutes of this type of data per person. But with this precision mapping approach, we actually acquire 1 to 5 hours per person. And this is spread across multiple sessions. You don't have to do that all at once. So 5 to 20 minutes, the standard amount that we get, gives us data that looks like this, okay? But in order to make a clear brain map, we want it to look more like this. Now, it turns out that this approach, getting hours of data, can actually help us do that, which is great. And then we can see what each individual's brain looks like. So a group of my colleagues and I actually set out to do this, but first we actually needed to test this approach in a group of just typical young adults, just to see if this was even feasible and what we could get from it. So we had 10 adults come in for 10 scan sessions, and we collected a total of what amounted to 5 hours of this resting state fMRI data from every single person. So this is what this group average brain map looks like. That's the group. But can we look at individuals? And we can, and here they are. So it turns out we were able to actually reliably map out each person's individual networks if we had a lot of data on them. So overall, if you just stand back and look at this, you might notice they all follow a very similar broad organization that kind of matches the group. So the general location of the different networks, the different colors, follow the same pattern. Orange is always in this area. Purple is always kind of areas, things like that. But we can also, with this approach, find some individual differences. So for example, we found these little patches in the brain that belong to one network in some subjects, but another network in other subjects. So I'm just pointing that out with the arrows here. So it's pointing out in 5 different people, they have this little yellow patch in this area, but the other 5 didn't have this. So now the question is, okay, we have this individual difference in the brain. Does this relate to anything, like some aspect of behavior or cognition? We're actually currently investigating that. Okay, so this shows us that these results, this approach is promising. But I really wanted to know if we can use this precision mapping approach in children, and specifically children with Tourette's. We know, and I know from a lot of research, is that it is harder for children to do long scans or to come back repeatedly for multiple scans. We also know that children, especially those with tics or any other developmental disorder really, that they move more than typical adults in the scanner. And like what was talked about earlier, movement is not a friend to MRI. It can basically make the picture blurry and cause some problems. So we really want to minimize movement in the scanner, which you can imagine is difficult for children with tics. We do have a lot of approaches to work with that though. So the next step in my lab was actually to test feasibility of this approach in children. So I want to show you what we've done so far. I think it's very exciting and promising. So we have successfully scanned 9 typically developing children, so children without Tourette's or any other disorder. They were 9 to 10, and we've also scanned 3 children with Tourette syndrome, 8 to 12 years old, 2 of which had comorbid ADHD. And so on all of these kids, we brought them in for somewhere between 3 to 12 scan sessions, which means that across all those scan sessions, we were actually able to get 1 to 5 hours of resting state fMRI data per child. So that was great. We showed that we could do this. I want to say this was not trivial. We really had to refine our strategies as we went along to see what we needed to do to get good data, help people hold still, just really make it more of a fun, easy experience for the child and the family. And so these strategies are working. So this I find very promising. So now we're actually still working on analyzing the data, but I do want to just give you a sneak peek at the brain maps that we have so far, because I think they are pretty. So in the middle here, we have our group average, but then around it, you see the brain maps for many of these individual children. And 2 of the children with Tourette syndrome are shown at the bottom here. So again, like the adults, if you stand back, you see these overall similarities and where these networks are, where the colors are. But there's also clear individual differences here when you look at the details. And so we really want to explore what these individual differences might mean. Okay, so I've shown you what we can do with this method. We can get these individual brain maps from children and from children with Tourette. So where do we go from here? So one question that I want to tackle is, do individual differences in networks relate to the heterogeneity in Tourette syndrome? So here are those brain maps from the 2 children with Tourette's that I showed you from our study. The arrows here are actually pointing out 2 different regions of the brain. So yes, they are close to each other, but if you look carefully, they're actually on different sides of a bump. Okay, so anatomically, they're different brain regions. But you can see that both of these spots are colored purple. And so purple represents one of these networks that's actually involved in cognitive control. So these 2 children have different distributions of this cognitive control network. So the question is, does this brain difference map onto differences in things like these children's symptoms or something else with respect to their clinical profile? And so with enough children, more than 2, we can really look into this question. And then another question that I really want to address is, how does tick-related brain activity map onto individual brain networks? So what we can also do when we scan people in this way is we can look at when they tick inside the scanner. And we can look at brain activity before, during, and after a tick, actually. So now let's just say, this is a hypothetical. Let's just say that we see increased brain activity in the region shown with a star during this child's ticks, okay? So looking at just the anatomy, like this, oh, there's activity here, there's activity here, we would say that different brain regions are involved in ticks for these 2 children. But if we look at their network maps, you kind of map that on to where their networks are, right? You can see that these stars fall in the same network. It's just that area pointed out with the arrow. So now we can see that the network involved in both these children is actually the same, right? So even though the anatomy is different, the network is the same. So it gives us some insight into the network involved in ticks. So that's just an example of what this approach can do, but there's a number of questions we can answer with this approach. So that is really the direction my lab is headed. And our first step was feasibility, and I think we showed that we can do it, which is excellent. So what do I see as the future benefit of this approach? So the major thing I see is that it has the potential to inform personalized treatment and clinical care. So how? Well, I think that understanding individual differences in brain organization can provide insight into the heterogeneity of Tourette. So if we understand how the brain maps onto, say, different symptoms in different individuals, we can now target those brain regions or those networks specifically that are involved in a given person's specific clinical profile. So what is that signature for that person? Also, knowing the brain networks that are involved in tics, or we could look at related phenomena like the premonitory urge, so look prior to a tic, that can actually help guide specific treatment targets. So let's say we identify a network that's involved in someone's most problematic tics, we can guide treatment in that way. So one example would be using something like TMS, or transcranial magnetic stimulation, which you may have heard before. Researchers are testing this as a brain stimulation treatment. Or something like TMS paired with a behavioral therapy like CBIT. So that in that way, you can actually target the tick with CBIT behaviorally, and then target the brain network involved in that tick if you have that specific person's brain map. So the ultimate goal is really to understand what's going on in an individual person with Tourette syndrome, both at the clinical level and at the brain level. And that ultimately, I think, can help us move towards this idea of precision medicine. That's the big goal. Okay, so I just want to thank everyone involved in the research, all my funding sources. Again, the Tourette Association, and of course, all the participants and families who really make this possible. And if you are in the Southern California area and you're interested in participating in studies like this, I put my lab information up here and contact information. Of course, right now, we're not actively scanning due to COVID restrictions, but I'm hoping that by fall, and so at that time, if we can start, we will be looking for children with Tourette's who want to contribute to this research, who want to get a detailed map of their brain. So if you're interested, feel free to contact me. I can put you on a list that we will hold until we are actually scanning again. But all right, thank you again.
All right, thank you so much. So let me move to the questions and see. So do the fMRIs only look at activity in the cortex? What about activity in deeper structures such as the basal ganglia?
Yes, you can look everywhere. That's part of the beauty of fMRI. You can look at the whole brain. So I have done quite a bit of work looking at subcortical structures like the basal ganglia. And so we are using this approach. You can actually find a map like I showed you in the cortex. We can do a similar map in these subcortical deep structures to see individual differences there as well. So that is actually another direction of study.
Great. And then let's see. What effect does reduced white matter volume mean?
That's a great question. That is exactly the type of thing we need to figure out. You can speculate, and you can speculate in many different ways, but we don't actually know. So we find these differences in the brain. We don't necessarily know what it means. And so what we can do is we can try to see if we can look for relationships between that difference in the brain and things like symptom severity, different types of symptoms, things like that. With these group studies, a lot of subjects, in order to be able to find correlations that you would think of as trustworthy, really. So that's where I think this precision imaging is hopeful, because then maybe we don't need as many people in order to look for these relationships between the brain and someone's symptoms.
Thank you. And then another question is there a relationship between Tourette syndrome and Chiari malformation? And
I have not heard of that, of any link there.
yeah, I haven't heard of a link there either. So yeah, so I guess Chiari malformation is when, I guess, brain tissue kind of goes down into the spine, I believe. But yeah, I don't know of a relationship with that.
No, I don't actually know of any relationships between Tourette's and any other structural sorts of abnormalities in the brain.
Yes. Okay, well, thank you. And then someone is asking if the webinar will be posted anywhere to refer back to. My understanding is that it will be, but I guess our TA admins can speak to that maybe a little bit later. I believe they'll send you an email when it's done as well. So, okay, well, on that note, let's move ahead. So next we have Matthew Capriati. So Dr. Matthew Capriati from the Department of Psychology at San Jose State University. And he might have some internet issues, so we'll just wait a moment and see if he's able to get on. All right. Is it working? Are you muted?
Can you hear me now?
Yes, I can hear you.
Okay, beautiful. And then you can see my screen too, right?
Yep.
Okay, great. So it wouldn't be 2021 without some technical difficulties. Big thanks to the SoCal Tourette Association and UCLA for inviting me. I'm looking at the attendees right now. I've been giving talks across the country and I guess across the world on Tourette syndrome for a decade now. I've never given a talk where 162 people were there about Tourette syndrome. So thank you for tuning in and coming out today. And I'm really excited to be here and have the chance to share some of the work we've been doing at San Jose State with y'all. I gave this talk a sciencey title. I wish I called it this. What I'm going to do is tell you about two stories, two research studies, both related to kind of tech and Tourette syndrome in some way, but also share some of the kind of ups, downs, twists, turns, and the people involved along the way to bring in a little bit of that. These are my financial disclosures. A big thanks to the Tourette Association and the American Academy of Neurology for providing a grant to fund the first project that I'll talk about. I received some speaking fees from the TAA for trainings on behavioral treatment of Tourette syndrome, but I don't make any money off the sale of CBIT manuals or anything like that. All right, this is the major hospital at UCLA where Dr. Ricketts and Dr. Passantini work. This is the Children's Hospital at Stanford where Dr. Espel works. This is the Children's Hospital at UCLA where Dr. Green works. Apologies if I've gotten the exact buildings wrong here. I know for UCLA it's actually across the street, but equally big and impressive. Wanted to show these to provide some contents. This is where I work. You can see it's sunny and beautiful. The grass is nice. But if you're looking at that and you're like, that doesn't look like a hospital. This doesn't look like where I would go to the doctor. This doesn't look like where they would have an FNIRS or an fMRI machine in that building. You would be correct. So the research I do is at San Jose State. It's a kind of typical college campus. It's a great place to work. So many opportunities there. Get to teach a lot of just bright, motivated young college students, a lot of whom are the first in their family to go to college. We do a lot of training of psychotherapists to go work in the community. But one of the things being in this setting does mean is that when we're looking to do research with folks with Tourette syndrome, we need to think about collaborating and finding ways to do work that'll work in a setting where we don't have a clinic and we don't have necessarily like brain imaging equipment and that kind of thing. So just that's guided a lot of the work we do, and it provides some challenges, but it's even more than that, provided a lot of opportunities. The first study I'll talk about is one where I was here doing some of the work and collaborating with folks at the University of Florida in their TIC center there. Dr. Espel talked quite a bit about CBIT. Hopefully most folks have heard of it. Briefly, it's a 8-session behavioral treatment where you meet with a therapist and you work on skills to manage tics on your own terms, and also basically ways to check out your own routines and ways you're interacting with family about Tourette's and tics to make sure basically what's happening is it tricking your brain into ticking more. And if it is, we undo those patterns in routines and interactions. CBIT works really well. It works about as well as medication without any side effects. So we're at a point now where guidelines from the American Academy of Neurology and groups in Canada and Europe recommend CBIT before medication in the vast majority of cases. So lately, we know that more people are getting CBIT, but most people still aren't. In 2008, which is 2 years before I started doing this work, there was a survey done, and you could see about 1 in 20 people had done CBIT, 1 in 20 people with Tourette. In 2018, the Tourette Association did an impact survey and found that that was a little more than a third of youth and about a quarter of adults. So this is a huge improvement, which is great, but it still means that about 2/3 to 75% of folks are not getting CBIT who could. So why aren't people doing CBIT? There are a number of different reasons. I'm going to focus just on some of them, but I want to highlight this is not exhaustive and there are other barriers. I'm going to focus on the reasons that have to do with treatment access. So what you see here is an aerial shot that's roughly in the town that I grew up in, Bradenton, Florida. This is actually, 8 to 10 miles east of where I grew up. If you think it looks kind of like a lot of nothing, you'd be a little wrong. Technically, there are sod farms there, there's woods. And if you go kind of off into the distance, you get into an area where there are shops, strip malls. I grew up about, I would say, a 20-minute drive from a Walmart. So it's the kind of place where there's stuff around. Where I grew up wasn't quite rural. The communities near us were. Anywhere in that picture, right, you're living in a geographic place where there isn't going to be good in-person access to any kind of super specialized medical care. You're going to have to drive to get that. This is where I live now. San Francisco, you can see there's a lot of traffic. I really wanted to make this a LA traffic slide, but I resisted the urge and just admitted that we have traffic here too in Northern California. I put this slide here to make the point that even if you live in sort of a big metro area, often just logistical factors related to getting across town or getting to a different part of your area where a treatment center might be can make treatment really difficult to access, particularly if you're looking for after school appointments or after work appointments, which mean that you'd be driving there during rush hour. Last but not least, our friend here reminds us that therapy is expensive, and that includes CBIT. Wind is cheap. I don't think that has much to do with helping folks with Tourette, but he thinks so. A big barrier to CBIT access is the cost, and a lot of CBIT providers are in private practice out in the community. Often folks in private practices that are not affiliated with a major medical center or hospital system, not just because of the business models that are out there and the low rate at which private practice providers are reimbursed by insurance for providing behavioral health services. It's often the case that they can't afford to stay in business and take insurance. So as a result, a lot of CBIT out in the community is really expensive, just based on things about our healthcare system. So we want to think about how do we decrease these barriers and expand the impact of CBIT. What you see in the kind of top and center there is an avatar representing what I will call tele-CBIT or telehealth more generally. This is where there's a provider and a patient connecting via a video conference and doing CBIT in real time, back and forth with each other, doing the same things they would do in a room together. Of course, in like the COVID era, we're all really used to doing this. To some extent, we're doing it now, though you're not interacting back with me. We're just so used to this, but this was a fairly novel thing when we started thinking about it about a decade ago. I want to mention there are other sort of tech enhanced tools that do have a lot of promise in expanding access to CBIT. So there's Tech Helper, which is essentially a self-help program that people can use to work on CBIT skills on their own, and CBIT Trainer, which is a tool that therapists can use to learn CBIT on their own. That's sort of in development. I'm going to focus on tele-CBIT today, which is again the back and forth in real time on video conference between a provider and a patient. Just really quick, previous research. So there had been 2 prior studies before the one I'll talk today about tele-CBIT. The first one I was not involved in. The data were collected around 2009, 2010. This was done by Mike Himley, Doug Woods, and some colleagues. Basically, this study found that when we use fancy equipment and we have people connect from a local clinic, so people drive from their home to a local clinic, the local clinic has some fancy computer equipment, and then they connect over telehealth with a provider somewhere else who also has fancy computer equipment. When we do that setup, we find that tele-CBIT works about as well as in-person CBIT for kids and teens. In another study, which was Dr. Ricketts' dissertation study, which I had the pleasure of being a therapist on, we did something a little different where we said, okay, what if we cut out this whole driving to a local clinic piece? And what Emily wanted to know was if we just provide CBIT to people directly in their homes over Skype at the time, will that work? And just using regular equipment in homes and on the therapist end. And I would summarize the findings of that study as yes, that kind of tele-CBIT works better than getting no treatment. It was compared to a wait list. But there were some signs that it might have worked a little less well than in-person CBIT. Nothing definitive, but some things in the data that made us wonder. We wanted to do the study I'm talking about today to basically further evaluate in-home tele-CBIT because we thought it had a lot of promise. Other than just more is more and more is better, there were a few particular reasons why we wanted to do this additional evaluation. One was that just tech had come a long way from when we did this study, 2016 to 2019. From before that, like 2009 to 2014, tech itself had gotten better, webcams, internet connection speed. People had gotten better at using tech. So me as a tele-CBIT therapist got a lot better from when I was doing that at first, more comfortable on video than to when I was doing it in this study. And people on the patient end as well, more comfortable with video chat. We wanted to see in this study what would happen if you actually embedded tele-CBIT into a comprehensive medical TIC program that I'll describe more in a second. And we wanted to include adults in the study because the two previous studies had only focused on kids and teens. So we asked basically 3 questions, which you see here under AIM 1, AIM 2, and AIM 3 in this study. First, we wanted to know, do people want to do tele-CBIT and did they like it when they do it? Second of all, we wanted to know, are people who do tele-CBIT able to do it smoothly? I'll talk about what we mean by that later. And third, last and certainly not least, does tele-CBIT help people with their tics? Is it effective? So I mentioned I partnered with folks at the University of Florida, Carol Matthews, Irene Malati, and Heather Simpson mainly. In there, what you see in the white represents the services that folks could already get at their clinic. So we did this study with folks who were patients at different clinics at UF. They could get really expert medication management from psychiatrists and neurologists there. They could get face-to-face CBIT from a really great team of occupational therapists and some psychologists, and they could get great treatment for co-occurring problems. So this is part of a Tourette Center of Excellence, really kind of state-of-the-art services there. What we wanted to see is what would happen when we added in-home tele-CBIT as an additional option. Our average participant, we had 19 youth. I can talk about this more in detail. I'm happy to follow up with all of the details and more kind of scientific minutia of this later in the Q&A or over email. But our average participant here was about a 12-year-old boy, more often than not had some co-occurring mental health condition that came along with his Tourette syndrome. We also had 10 adults participate. About half of them were kind of young adult age, and the other half had ages across their 40s, 50s, and 60s. So we wanted to know, did people want to do tele-CBIT? When we offered this, would people say yes? This figure shows kind of the cascade through different parts of the journey into starting our study. So from being offered CBIT to calling in and completing a phone screen with me about it, then to doing a longer baseline assessment to confirm that it would be a fit. The take-home point here is what I've put the giant red arrows pointing to. It's that for both kids and adults, about a quarter of the people who are offered tele-CBIT in their medical appointments actually began treatment. So did people want to do tele-CBIT? I would say, yeah, many, but not most. Did people like tele-CBIT when they did it? What I'm showing you here are data from youth, their parents, and adults. This is a single question that we asked at the end of treatment on a survey. How satisfied were you with the care you got through tele-CBIT? We asked a lot more questions to look at this in complicated ways, but the complicated ways tell you the same story as here. People are by and large very, very, very satisfied. You see this one person, this one parent, 6% very dissatisfied. Uh-oh, did something bad happen? I looked because I was concerned, frankly. And I looked down and they checked very dissatisfied for every question. And then the qualitative comments, the feedback they gave in words was glowingly positive. So my hunch is that this represents someone who got a little turned around in one of our many online forums and not someone who had a very negative treatment experience, but presenting the data here in full transparency. So yeah, people like tele-CBIT a lot. Would it go smoothly when we did it? So we asked 3 questions about this. First, we wanted to know, would people kind of stick in treatment, or would it be difficult in ways that led people to discontinue? Well, everyone who started treatment finished treatment and got the planned number of sessions. Second, we wanted to know, would tech problems get in the way of things? We found that for about 9 out of 10 therapy sessions, 87% if we're being technical, there were no major problems. So sure, there might have been sound cutting out for a minute. There might have been me getting confused for a minute about how to unmute myself, like happened at the beginning of this talk. There might have been a little video lag, but 9 out of 10 times, there wasn't a tech problem that got in the way of us doing the work of therapy. And we thought that was pretty neat. We also didn't see any safety problems. I can talk more about what those are, but we didn't see them. So did telecebit go smoothly when we did it? Yeah, very much. Last but definitely not least, did telecebit help people with their tics? These are the data from our 19 youth. What you see on the left is a measure of tic severity at pre-treatment and post-treatment. You can see that that line goes down. So tics went down on average for folks, and that was statistically significant. On the right, you see another measure, which is we had an independent evaluator. So this isn't just me working, rating how much better people are getting in our work together. This is Brianna Wellen working with Mike Himley at University of Utah, making these assessments independently and talking with folks before and after treatment. One thing you see in those data is that 13 of the 19 youth in our study got better. And by got better here, we mean they had a game-changing response in their tics. Technically, that they were classified as very much improved or much improved on the Clinical Global Impressions Improvement Scale, if you want to get technical. But about 7 out of 10 folks had a game-changing difference in their tics with treatment. And really similar results for our 10 adults. So did telecebit help people with their tics? Yes. Take home point, in-home telecebit's pretty neat. People like it. It tends to go smoothly and it helps with tics. A few things to note there. We can't compare rates to other studies. So this study, because we didn't compare telecebit to in-person cebit, it doesn't tell us if it's about the same as, better than, or worse than in-person cebit, or the outcomes. We don't know that. We would love to study that directly. I'll talk about that in a second. There is a single expert therapist, me. I am unusual among therapists in that I've spent 12 years with Tourette syndrome being the thing that I spend my time with professionally first and foremost. Most people who you get cebit from in the community know quite a bit about Tourette syndrome and have learned the treatment, but they haven't sort of gone that gung-ho with it. So there's some sense where that might be a little unusual. On the other hand, though, this whole model where you can use telehealth to connect with an expert who's at a UCSF or a Stanford or a University of Florida, a major medical treatment center, this whole model, that's part of the promise of it, that you can connect with someone who's pretty unusual and really does this with the bulk of their professional work. A big thing that I want to do more follow-up around is understanding the reasons why 3/4 of the folks who we offered telecebit declined it. So this was free treatment in your home with an expert and easily available after school and after work appointments. So that takes care of a lot of barriers, right? We need to do more work to understand why people are, like how people are appraising cebit and telecebit now, and develop treatments and other supports and options that are a better fit for with what they need and where they are. I want to throw in a qualification too. This was all pre-COVID in one sense. So I think we need to be careful. We got to remember, we see these really good outcomes here when people opted into doing telecebit. We know a lot of people now with COVID are doing teletherapy because it's the only option available to them. So telecebit or teletherapy, because it's the only game in town when you have to do it, might work less well. On the other hand, in COVID, I think we've also all gotten a lot more comfortable using video technologies. So there might be reason to think it would actually work better now. Here's what happened after this study. I did not turn in it to SpongeBob, but I was broke with regard to research funding. Again, last study made possible by a grant from the TAA. Some colleagues and I are still working on getting the federal government to give us some money to do more research on telecebit. Can talk more about that, but I won't go into it here. After this study, we didn't have that money though. I was still in a place where we didn't have a Tourette clinic where I love working. I didn't want to, leave. So we thought about what are other studies we can do while we're working on getting that telecbit funding, and that'll still tell us interesting and useful things about Tourette syndrome. We thought about one of the big assets that we do have at San Jose State, which is a really team of awesome, bright, motivated students who are kind of just starting out in their study of psychology, Tourette syndrome, kind of just starting out in their careers and really ready to do some good work. One of these students in particular wanted to do a study on stigma and social discrimination in Tourette syndrome. She was really drawn toward this, and a lot of our students are drawn toward advocacy, social justice, which is great. So as we thought about doing this study, we said, well, we don't have a Tourette clinic. If we did, it'd be great. We could ask the people who are kind of coming in anyway. And these students, they're moving through the lab for a year, maybe two at a time. These are not doctoral students where they can spend 5-6 years, finding, kind of slowly recruiting people for a study. They have to do stuff that's kind of quick. So we thought about, well, another way psychologists often do these studies to study things like stigma is they survey college students. So, you put a survey out to college students on their laptop and you have them answer questions. So they'd be doing like this guy right here. Well, that's great, but one of the things we know from these studies and just a lot of research on stigma, discrimination, and bias is that when you ask people their attitudes toward marginalized groups or potentially disadvantaged groups, something called the social desirability bias happens. And that means people say nice things. They figure out what the nice thing is and they say it. So it can be hard to evaluate in this kind of setting people's attitudes as they genuinely are. We can get an overly positive filter. So we thought about, gee, where could we go to find people's attitudes in ways that are not overly positive and are out in the world? And we said, aha, how about social media? What if we looked at what people tweeted on Twitter about Tourette syndrome? And first we thought about this sort of as a way to get this information in an unbiased way. But then as we went forward, we realized, wait, there's actually, even though we know people with Tourette syndrome and other chronic health conditions and just people in general interface a lot with social media about things that are relevant to them, we realize there's actually really little research on what people discuss on social media about chronic health conditions, and none on Tourette in particular at the time we started this study. So what we wanted to do was look at Twitter and just see what are people talking about, and kind of who's talking about what are the themes getting talked about, and then what attracts the most attention or signal boosting. Because we know on social media, things that get the most likes, retweets, and interactions are boosted by an algorithm, so more people see them. So how we did the study, we did something called scraping. We scraped 1,000 tweets that mentioned tics, Tourette, or other terms like it. This doesn't mean that someone literally painfully scraped these out of a computer hard drive. It just means you write a simple computer program to pull down those tweets into a database. Then we used a careful analysis called grounded theory to determine the main themes in these tweets. We recorded the tone of each tweet. We recorded if the user seemed to be personally impacted by Tourette syndrome. And we recorded how many likes and retweets each tweet got. Here's what we found about what people tweeted about Tourette syndrome. The most common theme was information about Tourette. This could either be scientific information, so like people sharing research studies or kind of professionally published statements from the TA or something else. But most commonly, it was just information based on lived experience. So kind of informal information sharing. About 25% of the tweets, 27% of the tweets contained insults and jokes. Unfortunately, these were mostly jokes where people with Tourette syndrome were the butt of the joke. They were pretty negative by and large. We saw a very small percentage, like less than 10% of these, were people, sort of using humor to cope with Tourette. It was mostly pretty negative, I would say. There was another theme that we call proposing diagnosis, where people were noticing a behavior that maybe a celebrity was showing or an athlete was showing, or just someone in their lives was showing, and they were sort of suggesting that this might be a tic or it might be Tourette syndrome. Sometimes that was neutral. A lot of the times it was pretty negative. We did see a chunk of tweets, which is one of the things we were excited and hoping to see a lot of, that showcased people living well with Tourette syndrome or showcasing resilience. That was about 10% of content. We also saw tweets that talked about tics in the context of political commentary or political figures and sports and athletes. Overall, the tone, we saw about 2 negative tweets for every 1 positive tweet. Happy to, again, share more of the detailed data. We looked at who tweets what. We saw that tweets with information and tweets that showcased resilience were more likely to come from people personally impacted by Tourette syndrome. So either based on their social media presence, it seemed like they had Tourette syndrome, or they were tweeting about a friend or family member who had Tourette syndrome. These other topics, jokes, insults, proposing diagnosis, politics, and sports were more likely to come from people not personally impacted by Tourette syndrome. And we didn't see any differences in what kind of content or what kind of users got the most likes and retweets. So we didn't see anything there. So summing this up, it seems like the Tourette syndrome discussion on Twitter happens both in ways that we would be inclined to think of as good and ways we'd be inclined to think of as bad, negative, or counterproductive. It does seem like if folks orient to or follow users who are personally impacted by Tourette syndrome, that cuts down on a lot of the bad, negative, or counterproductive content that you're running into. Doesn't eliminate it to zero, but it seems to cut down on it. I want to end by thanking all the folks who have made this work possible, patients and families who participated, fabulous team of external collaborators, and our large SJSU team. And open it up for questions from there. Thanks again so much.
All right, so I apologize, we're going to need to move quickly, and also we are running 10 to 15 minutes behind schedule, so if the audience can stay on past one, we would love that. So one question is, how did you differentiate between insults and proposing diagnoses?
Yeah, so this is a really good question. We were able to code both, so tweets could fall in multiple categories. So often, if it was in an insulting way, suggested that someone had tics or movements they can't control, often tweets were categorized as both an insult and proposing diagnosis. Okay,
thank you. And then I'll just do one more. What do you think about the effectiveness of Tick Helper?
I don't know. I think there's some data coming out soon about that. I think it's a really promising tool to add to the toolbox.
Okay, great. And I'm sorry, everyone, I know I'm neglecting your questions. We will address them by email or try to type them in during the next presentation. All right, well, thank you so much, Dr. Capriati. All right, so next we have Dr. Sandra Liu from our own program at UCLA, the Department of Psychiatry and Biobehavioral Sciences. All right, so she will get set up now. And then can you stop sharing yours? Can you click the stop button? It's like the little square on your control panel. Perfect, thank you.
Unmuted. I'm unmuted. Hello, can we, did I do this right? Okay, are we good?
Yep, it looks good.
Okay, great. Hi, everybody. Thank you for staying, and thank you to Emily and John for inviting me to participate today. To start with my financial disclosures, I actually just have NIH funding for all of the data that I will be talking about today. I don't have any other financial disclosures. So as you can see from the title of this talk and from other presenters today, studying the brain during free movement in humans is quite a challenge. And that is actually what we propose to do in these set of studies that started about 7 or 8 years ago. And so in order to do that, we needed to move away from the traditional MRI-based technologies that you've heard so much about today, and move to something that allows movement and mobility. So in our case, it was called MOBI, or mobile brain body imaging. And the idea here is to use brain waves, or EEG, to look at brain activity while we have freely moving humans, potentially in natural environments. And we were looking at a number of questions across, you know, voluntary movements, so cued behaviors where we had a visual cue and we asked kids to do certain movements. Across involuntary movements or tics, and for our control subjects, we actually had them just do blinks. Across a task that just involved cognitive inhibition or suppression. And then tic suppression and then reporting of premonitory urge. So really we wanted to look across these various dimensions of movement and suppression and brain activity involved in all of those things. And so we had quite a large sample, 103 children, 65 kids with tics, and 38 comparison children between the ages of 8 and 15. We were looking at several different conditions, as I've kind of described to you, tailored to our experimental questions. So, in one condition, we asked them to just go ahead and tic or blink freely. In another condition, we actually just verbally asked them to try and suppress as many tics as possible. And in this condition, importantly, and related to data you'll see later, we asked them to really focus on their tics, focus on when a tic was coming, and then to do their best to suppress it. And also during that time, they were using a joystick to express how much premonitory urge they were experiencing in order to express that tic. A third condition was reward suppression. So same as verbal suppression, please try to focus on your tics and suppress as many tics as possible. However, we also added another little piece to it, which was that the computer was monitoring how many tics, and that the children would receive a reward for how many tics they suppressed. Finally, we did this cognitive suppression task where the children were actually instructed to go in the opposite direction, to focus primarily on the task at hand, to do the best that they could, to not think about anything else, including their tics, but just to do the best that they could on the task, and that they would also receive a reward for good performance on the task. And then we used this EEG cap with 128 electrodes, and we used high definition video to record any tics or blinks that might be occurring during the session. So I'm just going to cut to the chase and tell you a little bit about and just summarize across our various experiments. So across voluntary movement, involuntary movement and suppression, and actually cognitive suppression, we saw that brain areas associated with attention, what Dr. Green called top-down attention, are key to tic expression and suppression. So this is differentiating from maybe some of the more subcortical regions that we think are very involved in tic generation, for example. And these are actually fMRI images, just to give you an idea of the areas we're talking about. So really kind of in the frontal and parietal regions, these areas are linked to top-down attentional control. And these were also areas that we saw that were quite activated in both children with and without tics during expression and suppression of movement. And here you see, this is, did my screen go away?
It is not filling up the full screen anymore. Is
better?
Yep, perfect. Back on. Yep.
Okay. So here you can see this is actually a functional connectivity plot during the cognitive suppression task. And you can see here, these are the what we call the edges, the primary connections that we saw among both children with and without chronic tic disorders. You can see here in the legend that the red lines were actually stronger connections among children who did not have tic disorder, and the blue lines show you the stronger connections among the children with tic disorder. So we can see that there is stronger connectivity in these frontal and parietal regions for kids with tic disorders compared to those without tic disorders. And then when we looked at those connections as well as activity, we saw that they were associated with a number of different things, not just whether someone could express or suppress a tic, but whether it was also associated with tic-related impairment, so the YGTSS impairment score, their accuracy on their cognitive inhibition task, and then other measures of executive function that we look at with regard to behavioral regulation and hyperactivity and impulsivity. So really very wide-ranging and quite important. But we wanted to ask another question. And so we know that attention is important, but there are these there are studies that have looked at attention towards tics. So this is kind of the foundation of CBIT, for example. You're going to monitor for an upcoming tic, and so you're really paying attention to your own body awareness and trying to monitor for the emergence of another tic. As opposed to, so I'm a clinical psychologist, and I have definitely seen patients who have tic disorders, but when they're engaged, very engaged in another activity that has nothing to do with their tics. For example, I saw an adolescent male who was a concert pianist, and his parents would remark to me that when he was, deeply engaged in playing the piano and a long protracted piece on the piano, his tics basically went away. And there's a very small literature at this point looking at whether if you direct your attention away from the tics, whether this might be a successful strategy for reducing tic expression. So we wanted to test that particular idea, whether attention directed towards the tics or attention directed away from the tics was more successful in decreasing tics. And here is your answer. So what we did was we looked at tics across conditions. So let me just orient you to this graph. So these are, this is a tic-freely condition. These are the verbal and reward suppression conditions. So again, remember, we asked children to pay attention to their bodies, and when they felt a tic coming, to suppress the tic. So this is the verbal suppression condition, and this is the reward suppression, where they were actually being given a reward for how many tics they could suppress. And then this is the cognitive suppression task that they did. And again, remember, we instructed them to think only about the task, to do the best they could on the task, don't think about anything else, and that they would get a reward for good performance on this task. Okay, so as you can see here by the bars, so this is how many tics they showed per minute across these different experimental conditions. So from tic-freely to verbal suppression, there was a significant decrease in tics per minute. The decrease from verbal suppression to reward suppression actually wasn't significant. It was close, but it wasn't quite significant. So even just adding a reward to this verbal suppression condition did not actually lead to a decrease in tics. And then during the cognitive suppression condition, again, quite a significant decrease, even from this reward suppression condition, in the number of tics per minute. Seen a different way, this is actually mapping the percent decrease from tic-freely. So this was each person's baseline. And then we looked at how much of a decrease, if they showed a decrease in tics, how much of a decrease they showed by condition. So again, here, the difference between verbal suppression or attention toward and reward suppression was actually marginally significant. But then there was a really large decrease in tics when we had the children focus on something away from their tics, about a 20% decrease in tics when they were focused away from their own tics and focused on something else. So now we're going to speculate a little and how this can potentially guide treatment. Because of course our goal is always to deliver the right treatment to the right person every time, as President Obama said in 2015. So do we have, how does our finding, our data with regard to attention away and attention toward guide us in terms of treatment? Well, like I said, attention toward tics is kind of the mainstay of CBIT. And so this is just a pictorial description. So, you know, if you have hand clenching tic, the compensatory competing response may be to put your hands underneath your legs or to clench your hands together. And, you know, but of course the foundation of that is you're paying attention, you're monitoring at all times for when a tic might emerge. This is the empirically supported treatment and has been studied many, many times. We know the long-term outcomes are really good. As opposed to something like mindfulness or yoga, or even, you know, getting fully engaged into something else that takes your attention away from tics. Clearly, the data that I presented today would suggest that this might be the more effective, at the group level, the more effective strategy. However, this is not empirically supported. This is not, there are no protocols that I'm aware of that have been integrated into Tourette treatment where anything like this has been developed yet. So it's something that I think we have to take into consideration when we talk about what the treatment implications are of the data. Okay, so in that same data set, using a threshold of 25% reduction in tics from tic-freely, we identified about 2/3 of the sample were what we labeled as good suppressors, meaning they could reduce to at least 25% of their tics from the tic-freely condition in the verbal or reward suppression conditions. The remaining third we called bad suppressors. So they were not able to reduce their tics across the 3 conditions from tic-freely to either verbal or reward suppression, at least by 25%. Now, of those kids who weren't so good at suppressing, we actually saw that in the attention directed away condition, 3/4 of them actually were quite good. So, and then another quarter weren't so good. So basically, I think the approach would be, since CBIT is empirically supported, and you do have a good number of children who will respond to CBIT, I think you start there. And then potentially, if they aren't able to suppress using CBIT, perhaps you think about alternative treatments. Medication, of course, is another possibility, but you could also think about maybe incorporating some other sort of something that directs their attention away from their tics, and you may get a robust response if you can find the right thing. I also wanted to just mention non-invasive neuromodulation, which I believe Dr. Green also mentioned. So non-invasive neuromodulation are basically types of stimulation, brain stimulation, where you're using devices either kind of near the head, this is transcranial magnetic stimulation, or on the head or scalp, this is transcranial direct current stimulation. I'm going to talk about one more in a second, where you're trying to use stimulation to stimulate certain brain regions to increase or decrease activity, leading to relief in symptoms for a disorder. So, for example, TMS is being used, is FDA approved and being used for depression, and I believe OCD as well. So this has been quite effective in certain disorders. TDCS, I don't believe has been FDA cleared for any disorder, but it is quite popular, particularly even among young adults who like to game. But so far, in terms of the empirical results, TMS and TDCS for Tourette have been quite mixed. I want to mention this other new form of non-invasive neuromodulation called external trigeminal nerve stimulation. So we have actually been doing studies on TNS in ADHD. And so this is kind of what the stimulator looks like. It's quite small. It's kind of cell phone sized. And then there is this patch that's worn on the forehead while the child sleeps. And so there's a very mild electrical stimulation that is delivered to the trigeminal nerve. So these are cranial nerves in the face, and there's 3 branches. And the V1 branch, which is in the forehead bilaterally, not just on one side, is the target of TNS. And so I'm not going to go too far into the mechanism of how, but basically these cranial nerves are stimulated, and then that actually comes down into the brain, deeper parts of the brain, and then seems to provide some activation in the brain, kind of radiating out. So it's actually an indirect form of brain stimulation, which makes it different than TMS or TDCS. Nonetheless, it seems to be really effective, actually. Well, effective in 50% of children, really effective in 50% of children with ADHD, where it leads to a reduction in ADHD symptoms, so inattention, hyperactivity, impulsivity. And then recently, we also looked at whether TNS results in improvements in executive function, which it does seem to do that as well. So this is an FDA-approved treatment now for ADHD. It's commercially available by prescription from your physician for the treatment of ADHD. So that might be most relevant for those who have chronic tic disorder comorbid with ADHD. Although this is from a recent study that we just did looking at 60 kids with ADHD. Half received active TNS and half received placebo TNS. And we were looking at treatment-related change in connectivity among kids with ADHD. So again, let me just point out this is in ADHD, not kids with Tourette. But this was the change in effective connectivity after 4 weeks of TNS treatment. And so this may actually look kind of similar to what that connectivity plot you saw during the cognitive suppression task. So basically, children who had active TNS showed reduction in connectivity between frontal and parietal regions. And that is actually the same sort of mechanism of action we are looking for in Tourette. So it looks like this lower connectivity results in better attention and better executive function. And that might be something that might be highly relevant for helping with reducing tic expression and increasing tic suppression. Okay, so our conclusions were that it is actually possible to measure brain activity and connectivity during movement. The brain regions associated with tic expression and suppression do appear to be heavily reliant or overlap with areas that we know are related to attentional control, these frontal and parietal regions, and that this seems to work. Actually, we see similar findings across voluntary or cued movements, tic urge, and expression and suppression. Treatment using attention towards tics is empirically supported, but we're finding that directing attention away from tics may be successful, particularly with those who don't respond to CBIT. But of course, we need more research, and we also need to kind of develop a treatment that would capitalize on that sort of finding. And finally, non-invasive neuromodulation, or TNS, is FDA approved for ADHD. And these mechanism of action studies, these changes in the brain related to the treatment, suggest that it may also be useful for kids with Tourette. Of course, that has not been tested in any way, and that more research will be needed on that as well. And just like everybody else, I'm going to encourage you, if you are living in the area and interested in being involved in research, we are currently looking for children 8 to 15 years old. It's a one-session experiment, one-session visit. We actually are open. We are able to see kids, and so if you want something to do instead of Zoom school, for example, or when Zoom school is done, please contact us. That's my project coordinator who would be happy to talk with you about it and answer any questions you have about the study. Thank you very much.
All right, thank you so much, Dr. Liu. And yep, so now I will move to questions. So did giving attention to ward ticks also include using a competing response?
Say it again?
Did giving attention to ward tick also include using a competing response?
It did not. It did not. So it was a suppression task. So we just asked them to try and suppress, monitor and suppress, and they would get a reward for suppressing.
And but what about times when you physically cannot have attention away from ticks in real life with many different activities? And what about overall reduction of ticks over time in attention toward CBIT versus attention away with activities of interest? So the first part, yeah.
Yeah, so I've thought a lot about that, and that is part of the issue, right? I mean, you can't just go start meditating or do yoga if you're in school and your tics are emerging. So I think that is the part where we need to do more research. We need to develop ways, and it may be quite individual, right? It might be one of those things where you know, if they need some sort of sensory stimulation, they can use a ball. I mean, I think there's going to be some play in individualization in terms of what works for what child, and so I think that is the key, is finding things that can be done kind of discreetly, or something that can be done in the midst of other activities, ongoing educational or sports or other activities that are happening, or even eating at the dinner table. What can be done in order to engage attention away? Another thought I had actually was, maybe I wondered if CBIT could be altered some way. I don't know. That's a fundamentally different approach. So obviously this is a brand new finding. I literally just have been running our data. And so I would need to think more about that, and of course consult with my colleagues who are experts in treatment of Tourette.
Yes, and then just one more is, so in the rewarded tick suppression condition, were rewards given immediately after successful suppression, for example, every 10 seconds, or were rewards given at the end of a session?
At the end of the session.
At the end of, okay, and how long were the sessions?
The sessions were about 7 minutes each.
Okay.
Yeah, so
right.
The child was told that the computer was keeping track of how many ticks they had suppressed. And then they were given the reward at the end of the session.
Great. All right. Well, we will try to address the rest of the questions either in our discussion or over email.
All right.
Thank you so much, Dr. Liu. All right, and now we will have Dr. John Pasantini come back up, and he will kind of tie everything together. And yep. Thank you for your attention.
Great. Thanks, Emily, and thank you to all of our speakers. This would be the point if we were doing this live, where we would give a round of applause to all of our speakers. So I would all of you to give a virtual round of applause, and we'll pretend like we can hear you. This was a fantastic set of talks. Really, this is really cutting edge stuff. I mean, some of these findings we didn't even know about even just a few weeks ago. So this format really allows us to do updates without having to wait for the several months or a year or longer that it may take to publish papers and get this data out. And, you know, I think even though we had talks ranging from stigma, Twitter stigma about Tourette's, to long-term effects of CBIT, to, you know, looking at brain activity, this all really does tie together in some really interesting ways, I think. So we know that behavioral treatment is effective. It's pretty effective. We know that most people like it. We know that it's not always easy to access, but with telehealth, and we've been doing telehealth CBIT in our clinic for over a year, as have many of the CBIT providers, we know that there are ways of trying to get this treatment out and make it more accessible to people. That's really exciting. But as with any treatment, and even good treatments, and CBIT is considered a highly effective treatment, only about 50% of the kids that were treated in our studies demonstrated really strong benefits, and then another quarter or so had some benefit. So the treatments that we have, even though they're really good, they don't help everyone. And as Dr. Liu said, quoting Barack Obama, we want to find out which treatments work best for which kids under which circumstances. And I think today we learned a lot about the research that's trying to make this happen. So we know that that comorbid disorders, so we know that ADHD can impact response in some ways. We know from Dr. Ricketts' talk that OCD symptoms tend to be strong predictors of poor sleep in individuals with Tourette's, maybe even more stronger than the tics themselves. So we need to better understand comorbidities, and we're learning more about that through these studies and through other studies that are going on. How can we develop treatments that either target all of the comorbidities together or that focus on specific characteristics of Tourette's? And some of the brain research that's going on that we're doing, or other research, we may be able to find some common brain pathways. And you saw this in Dr. Liu's research, that maybe Tourette's and ADHD, they have some similar neurologic underpinnings that maybe we would be able to impact this, in terms of enhancing attention using a combined treatment or some kind of a broader treatment, which would be pretty efficient for kids. I think the most exciting work is that we are learning now how to measure brain activity associated not only with tics expression, but also with treatments. And we saw that from Dr. Espil and Dr. Green and Dr. Liu. For any of you that were involved in research in days past or have undergone an MRI or any kind of a brain scan, it's highly impractical, especially when you're an 8-year-old child with Tourette's and ADHD. The movement just almost makes it very difficult to get this data. But now we can, in some instances, we can actually gather brain data on brain functioning, brain imaging, brain connectivity, in individuals as they're walking around, as they're practicing CBIT, as they're suppressing their tics, as they're engaged in stressful situations. And by doing this, and as you saw here, some very preliminary data, learning about what different kinds of brain activities are going on, and how do the brain activity of kids or adults with Tourette's differ from those with ADHD or OCD or without any other kinds of problems. And by looking at these contrasts, we can identify the specific areas of the brain that are going to be important for treatment, both in terms of understanding, maybe better understanding the causes of Tourette's, and maybe we can develop some early intervention or prevention programs to try to strengthen these areas, perhaps ultimately in the future before the tics even start in younger children. But for present purposes, how can we use these data to try to better develop treatments? And what we saw here, and from Dr. Green's talk, the little yellow dots that differed. In some of the kids with Tourette's, they had the dots on the right side, and others had the dots on the left side of this little bump. And that's really important because we know that one treatment doesn't work well for everybody. And we know if we see 10 kids coming into our clinic for treatment of Tourette's, we're going to see 10 very different kids. And treatment may work in 5 and not the other 5. So in addition to looking at behavior, does the child have comorbid ADHD or OCD, executive function issues, we can now say, how does the brain of this child differ from the brain of that child? And how can we use that information to tailor treatment or make better treatments? The ultimate goal of all of this is really a more of a precision medicine approach to treating Tourette's, as with other disorders. And that was, again, President Obama's primary goal when he said, what treatments work best for which individuals. So if you come to your doctor with the fever and the doctor gives you aspirin, or you take aspirin for a fever, that works sometimes, but not always. And we know that fevers have very different causes: dehydration, medication side effect, inflammatory disease like arthritis, food poisoning, a viral bug, or a bacterial infection. So what we're doing with the brain imaging now is we're being able to tease out these different causes. We know that CBIT works well. It's kind of like aspirin, but we want to be able to actually tailor it to specific kids and adults, so that everybody that uses it gets the perfectly tailored approach for themselves. And maybe that is attention away, maybe that is attention towards, maybe that is combined with something that can help enhance executive functioning, or reduce ADHD. And again, this doesn't have to be from medication or imaging. It can also be from a behavioral interventions or maybe computer-based interventions. So this is really the goal of what we're trying to do. You know, with the last talk and, you know, attention away or attention towards with CBIT, I don't think that's a big dichotomy, because we do use a lot of attention away in CBIT. And one example of that is kids with vocal tics or adults with vocal tics. The common competing response is rhythmic breathing, slow rhythmic breathing in a direction opposite to that, to what you see for the tic. So if I have a sniffing tic like that, the competing response is going to be breathing in and out through my mouth. And if I'm breathing through my mouth, I can't sniff. But the other thing about the breathing in and out through my mouth, it can be very calming and very relaxing. And we tell our patients to focus on the breath as you're doing this. If I have a grunting tic, I'm pushing air out of my mouth. The competing response for that would be breathing.
Dr. Pasantini? Hello?
So I'm not sure what happened. The camera just turned off. So we have a really valuable resource here in the Tourette Association that's able to help us with this work. And I would encourage you to support them where possible. Again, I'd also like to really thank our presenters and Dr. Ricketts and Tracy Alexander from the SoCal chapter for their support. Megan Burns and Claude Schofield and Evie Contulis for helping us put this together. And I think we will end there. I believe the plan is for us to answer the questions we weren't able to answer in this webinar live, that there will be a written response to as many of the questions as we can that will be posted somewhere. So thank you all very much for attending and sharing this wonderful experience with us.
Yes, thank you, everyone.